Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, the University of Colorado, or the institutions and their guests. I'm really fortunate to be joined by my co-host, Dr. Rachel Frank, who's a sports and shoulder surgeon at the University of Colorado in Denver. Rachel, how are you?
Doing well, thanks, Pete. How are you?
Oh, I'm doing great. Today we have a really special episode. We've invited Professor Hiroyuki Sugaya as a guest. Dr. Sugaya is well known to most members of our society, but for those of you who do not know him, Dr. Sugaya is in practice in Tokyo in Japan and Chiba University. He's well known throughout the world for his arthroscopic techniques, and so we're really lucky to have him on. Dr. Sugaya, welcome to the podcast.
Hi, hello.
So
It's my
let's
pleasure.
start. Let's start
Okay.
at the beginning. Tell us how you first became interested in shoulder surgery.
Actually, I used to be a baseball player, and I got a shoulder injury when I was in university, and that was maybe 30 more than 30 years ago. And at the time, there's nobody who I can rely on. So that's why I started doing shoulder to solve this baseball problem. That was shoulder elbow injury.
What position did you play in baseball?
Pitcher.
So you were a pitcher and then you developed a shoulder injury and thought there was just no one that could help you.
Yes, that's right. Yeah.
Now, you've become widely recognized. I know Pete and myself look at your work and what you've done, and I think we're both in awe of what you've been able to accomplish and continue to publish on and talk about and describe. But you're really recognized for your arthroscopic techniques. How did you learn arthroscopy, and how did you become interested not only in treating shoulder injuries, but specifically with arthroscopy?
Yeah, the my the most my priority is to solve the problem of baseball player. So but regarding surgery, no open surgery is not a choice. So that's why I studied the arthroscopic surgery, and also I ran the arthroscopic surgery from visiting a lot of big guys in the U.S. like Steve Schneider and Burkhardt, and also their video and also in my country there's some the elder doctors. Then I developed the arthroscopic skill by myself, and then actually I started the shoulder arthroscopy back in 1996. That's my first case, and 1998 I decided to do everything scope. So because I need to treat a baseball player, so that's why the open surgery is not the choice. So that's why I decided everything done by scope. So during that time there are a lot of problem. Actually, some doctors already started the arthroscopic shoulder stabilization, and also, of course, in the early times, so there are a lot of failures. So that during the JSS Japan Shoulder Society meeting, the many doctors start to limit the indication of the shoulder stabilization arthroscopically. So that's why. But even though I decided to do everything arthroscope, so that's why I need to. How should I treat? How can I treat this patient arthroscopically? So then I need to see the glenoid shape. Then okay, let's see the glenoid shape. So remove the humeral head, and then we can see the on-face view of the glenoid, and that became my first study in the JBJS back in 2003. So I decided to do everything arthroscopically. So that's why that's that's why I invented a lot of new technologies and new ideas, and I published many papers.
Now, you talked a lot about just in there about things you've accomplished from an instability perspective. I think this is a place where you've made a lot of substantial contributions. I mean, you mentioned the JBJS paper on, the shape of the glenoid, the morphology of the rim. Probably one of the things that has really turned a lot of heads are the results of your repair of bony Bankarts, which I think is a topic you've really covered in depth. Tell us
Mhm.
what got you interested in this at first.
Okay, so when I see the patient who had a 16-year-old lady, she was a judo player, and she had a big fragment, and that was maybe about the year of 2000 or something. Maybe I remember 2000, May to year of 2000, and before that, I removed every fragment to mobilize the ligament well. But she had a very big fragment. So if I remove the fragment, they're gonna be, create stability is very difficult. So that's why I decided to utilize the fragment. So that's my first bone implant repair. That was in May 2000, May 2000, and that was very successful, fortunately. So that's why after that I decided to preserve the every fragment and incorporate fragment to the repair, even regardless of the size of the fragment. So that's my first body banker procedure, and I published in the body banker short-term outcome to the JBJS of 2005, and also a longer-term outcome 2015.
Now, in addition to your incredible work on the glenoid and morphology and bony bank arts, you've conducted so many other important research studies, and perhaps among the most influential has been your work on rotator cuff repair healing.
Hmm.
As you know, and as we know, your classification scheme is widely used, and your study on healing after double row repair has been cited over 1,000 times, which is incredible. Tell
Hmm.
us what initially interested you in the cuff, and what do you think the future holds for the cuff? Where will we be in 5 to 10 years with regard to rotator cuff repair and healing rates?
Hmm. Okay, so the actually I've been academy meeting from the 1996, and I saw the situation in the United States a lot. And maybe late 90s or around the year of 2000, the old arthroscopic rotator cuff repair is very rare. So actually, the many guys started the old arthroscopic from the year of 2000, and at the time, I thank you very much. Uh, yes. So the in the beginning, so I'm the maybe I started the single row for rotator cuff repair, and eventually I shifted to double row. And in the beginning, the my concern was how can I assess my repair integrity. So I checked every published papers, but there's no reliable criteria. So that's why I decide to make a classification on the repair integrity, and that's my beginning. And so fortunately, everybody's using it like recently, and that's fine. But I started doing that to assess my repair integrity. So the after that we did anatomical study. Maybe you guys know that, and we published in JBJS also back in 2007-8, an anatomical study, footprint study of the supraspinatus and the infraspinatus. So by doing this research, we understand what is the most ideal rest tension anatomical repair. So before that, everybody think that the supraspinatus inserts to the superior portion, infraspinatus inserts to the posterior portion of greater tuberosity, but we found that the infraspinatus inserts to the greater portion of the greater tuberosity, and the supraspinatus inserts to the very limited anterior portion of the greater tuberosity, and also limited to the lesser tuberosity, even insert to the lesser tuberosity. So that's why I think this anatomical paper contributed improved the repair integrity after surgery for I think many contribute to the many doctors. And you know so I think that maybe we already solved the repairable rotator cuff repair based on the anatomical study and the other things, and also the lot of good instrumentation like suture anchors and many things. So the problem was the irreparable one. But Termihata published an supercapsule reconstruction so that we can solve the using that technique for the irreparable patient. And also we started using the reverse shoulder arthroplasty from 2014. So that's why in the future, I think that right now the almost we can cover the majority of patients who has a rotator cuff problem. But I think the supercapsular reconstruction is we need to use an autograft to obtain a thick graft. But in the United States, I know the thin dermal allograft is very popular, but I think that's too thin to obtain the longer term good results. So right now we are doing the new researches to utilize the thick allograft from the animal. So it is not yet clinical use, but I think maybe in future we can utilize that. So that's why the reparable rotator cuff tear should be. I think it's okay. That in future we need to manage the irreparable muscle rotator cuff tear patient who has a problem, and but not indicated for reverse. So we need to do a lot of study from now, even from now. I think.
I wanted to follow up with you. You mentioned your an anatomical paper, the paper study with that you guys published with Mochizuki, where you, again, as you mentioned, demonstrated just how different from our traditional understanding, just how much larger the infraspinatus attachment was and how much smaller it was. Now the supraspinatus is more anterior medial and the infraspinatus is most of the tuberosity. This has really changed the way that I think about the rotator cuff. Has this changed the way that you perform your repairs?
Yeah, actually, that didn't change, but we confirmed that. During surgery, we recognize that. I recognize that if the patient has large tear, when we try to bring the posterior cuff to front, that's easy. But retracted the superior cuff to bring the bring back to the anatomical position is a little bit difficult. So that's why I think the anatomical study, like Crack and Harriman's paper is, I don't think it's real. So that's why we did this anatomical study, and so the results of the anatomical study didn't change my way of repairing, but we can confirm the what we were doing was correct.
One thing that I think would be helpful for our listeners is having your perspective on what advice you would give to young surgeons to have a career. I think even at, a percentage point as successful as your career. I was just thinking to myself, it's amazing that we're even chatting with you. I'm a little bit starstruck just to be able to speak with you on this podcast, and I think many of our listeners will feel the same way, getting to hear you, speaking with us in a casual conversation. But what advice would you have for young surgeons early in their career, perhaps trainees, residents, fellows, et cetera, to try to have an impactful career, just similar, or at least somewhat similar to what you've been able to do?
I think the young doctors need to have experience, but the experience we had was piled up in using them in 20 years, 30 years. So that's why the in order to get this kind of experience in a short time is the best way is to observe surgery. So you need to observe surgery always, you guys, and observing surgery of your mentors, but also you need to visit other famous doctors like Rachel Frank. So I think that's very important. So actually, I had a lot of input from the Steve Schneider, Patty Sabor, and Steve Burkhardt, and also Japanese doctors. And also when I travel outside, I saw other guys' surgery. And also the discussion with these notable guys and very very instructive. So that's why I the you need to minimize the period you have the experience and knowledge by observing or speaking with other famous notable doctors. That's the best way. And also you need to read a lot of papers.
I mean, I know our readers, or excuse me, our listeners won't be able to see this, but I'm blushing over here. So that was, first of all, what an answer, and so kind of you. It's just, again, it's amazing to hear your advice as a young surgeon myself, and I'm sure Pete's thinking the same thing. And reading the papers, hopefully contributing to the literature, and watching amazing surgeons do their work, I think really is influential for sure.
Mm. Yeah. And also the one more thing, is most important thing. One of the important thing is as I did clinical research in the past, if you face the clinical problem, you need to try to solve the problem by yourself by reading papers, asking expert, and then you find a new thing you need to publish, present, and publish papers. That's very important.
I wanted to ask you about that because I think one of the themes in what we talked about with all of the work you've accomplished is that you said, I encountered this clinically and then I studied it, and either I confirmed what I suspected to be true or I found something that was new or that was different. For instance, I discovered that it was easier to pull the cuff around the back, and then we confirmed with an anatomical study that the infraspinatus had a different attachment than was previously known. Or I had this suspicion that we shouldn't be cutting out the bone fragments because we were narrowing the glenoid, and then when I started repairing them, all of a sudden I discovered that they could heal, and that then we could restore the initial anatomy of the glenoid. So it seems like for you, a critical aspect has been recognizing intraoperatively or during your clinical practice, that there's that you've had an ability to observe problems or observe things that maybe other people have not seen. How are you doing that? Do you have a specific methodology for that? Do you have like a system of notes you keep? Do you have tell us about that, because it seems like that's the germinus for so much of your success.
Um, Actually, as I said before, I'm seeing many patients. In the U.S. and physician's assistant follow the patient sometimes, but I need to follow every patient every time. So that's why I got a lot of information from the patient before surgery and also after the surgery. So that's why I think that's that makes me very very busy, but to me it's fine. It's fine, and it's a fun. So then I see imaging, pre-op imaging, I see the pre-op function, and also I do surgery, and after surgery I see that many patients complain like neck pains, or some doing very well, and others don't. And also that I have a strong connection with the physical therapist, and they help me a lot after post-op care, and also the pre-op assessment. So that's why this is it's not just surgery. I think the shoulder surgeon need to see everything. That's my idea.
So do you have a physical therapist that works with you in clinic, or do you have a physician's assistant? Who assists you in clinic then to see that many patients?
I don't have physician assistant system. So we don't have physician assistant system, but we have a lot of physio. So very very reliable physio. As I said before, the starting point is how to treat a baseball player. So that's why the physio for this kind of a top athletes like a baseball and other sports is very very important. So that's why I'm a very strong relationship with the physiotherapist. And also I have more than 15 physio in my clinic. So I'm working with them every day. So the communication with physio, and they can they give me a lot of information about the patient, also that I can give them the information. So that's why a very good exchange.
What a team. And that's what it takes to get the results. So it's something that all of us can look and try to emulate if we can. One thing that Pete and I like to ask the superstars that come on this podcast is kind of a final wrap up question. And the question is, if you could have dinner with anyone from history, dead or alive, who would it be and where would you have dinner?
Okay. Oh. All right. Okay. Everybody who invite me, and also everybody who joined my clinic and surgery center.
That's a very good answer. Nice and accommodating for everyone. Where would you have the dinner? Would you have it someplace local near you or someplace in a different country? Where would you have it?
Anywhere. I don't know. The place doesn't matter. And meeting people, meeting doctors, meeting visitors, meeting teachers, and having conversations is very important over beer.
Ha, absolutely. Well, I think that's all the time we have for today's podcast. Both Pete and I want to thank you so much for joining us and for spending the time with us in your incredibly busy schedule. We are so thrilled to have had you, and I think our listeners are really going to find a lot of, they're going to really enjoy listening to this. So for all of our shoulder and elbow listeners out there, please don't forget to subscribe. And for Pete Chalmers, I'm Rachel Frank, and we'll see you next time.